So good afternoon. The case we're going to present today, it's for Mr. RT, who is a 56 years old, a pleasant gentleman, present with symptoms of depression. The history of present illness. Mr. RT is a 56 years old gentleman. He known to have a COPD, previous ST, elevated myocardial infarction, treated with PCI, represented the clinic today complaining depressed mood consistently in the last 6 months. Had loss of interest in his hobbies, innocent feelings of guilt, fatigue, and worthlessness. Does not spend time with he used to spend with his friends, and has lost ability to concentrate at work. Symptoms got worse with winter season, holidays. He has no suicidal ideation, no bipolar, mania, and anxiety or insomnia. Mr. RT first attack of depression was back in 2017 after PCI stenting post ST elevation of myocardial infarction. He has tried citalopram, worked well for some time, but it caused him sexual dysfunction and diarrhea. He got also COPD, as we mentioned before. Last exacerbation was March last year. No bronchitis for the current time, but he still has symptoms of shortness of breath while walking or exercising. On exam, vital signs within normal values. His body mass index 25.1. Lab findings, his HbA1c was 6.3. His forced expiratory volume 1, 60%. Forced expiratory volume 1 versus forced vital capacity 0.6, QT 457, which is slightly elevated. So the past medical history for Mr. RT, he has dyslipidemia, he's been suffering from overweight, he had ST elevated myocardial infarction, and he was treated with PCI stent 3 years ago. He still have a COPD, he's active smoker, and he is occasional alcohol consumer. Medication, Mr. RT is currently taking metoprolol, succinate 50 milligram daily, fluticasone 100 microgram twice daily, allopurinol 2 puffs every 4 hours PRN for shortness of breath, atorvastatin 8 milligram daily, aspirin 3 to 5 milligram daily, and he was vaccinated for COPD and pneumonia, and influenza, he has an allergy to adhesives. So according to our case and primary complaint for Mr. RT, we prioritize our problem list as follow: depression as his primary complaint, COPD as a secondary, and of course we have to treat the smoking and deal with the overweight problem. So we're gonna start tackling the depression problem, the assessment of the disease and drug therapy. Mr. RT presented 5 symptoms during the assessment out of 8 of depression, including loss of interest and consistent depressed mood for the last 6 months. According to DSM-5, it is a major depressive disorder with a moderate severity. According to the Hamilton D scale score was 60. Patient had tried citalopram 3 years ago, achieved improvement, but unfortunately caused unpleasant adverse reactions, basically sexual dysfunction, diarrhea. No information provided if he had completed the course of treatment or discontinued abruptly. So the goal of treatment is achieve a good response of medication, measured by 50% improvement of symptoms in 2 to 4 weeks, achieving remission in 10 to 12 weeks of initiating treatment, and to achieve Hamilton D score less than 7, and also we have to screen for suicidal ideation. Recommendation, so non-pharmacological measurement, we need to educate the patient about the importance of medication adherence. Second, he needs to call his doctor for a presence of any side effects, mainly suicidal ideations or thoughts. So he has to allow the medication to work 2 to 4 weeks. Psychotherapy, CBT or interpersonal therapy is kind of really important in his case. The rationale showed an effectiveness in several meta-analyses, a meta-analysis of 92 trials on 6,900 patients compared CBT with a control condition. Remission occurred in more patients treated with psychotherapy compared with controls. Also, because of his seasonal kind of depression, light therapy may be of a benefit to him. A 10,000 lux intensity slanted towards his face for 30 minutes, preferably in the morning, as patient stated that symptoms were worse during the cold weather and the holidays, so it may be effective to use that modality. In a randomized controlled trial, a combination of fluoxetine and light therapy demonstrated higher remission rate than either modality alone in patients with seasonal major depressive disorder. So combining psychotherapy and pharmacotherapy is more effective, was supported with many clinical trials. One example is a meta-analysis of 25 randomized controlled trial of 2,000 patients comparing pharmacotherapy versus pharmacotherapy plus psychotherapy, showing clinically small to moderate effect favoring combined treatment. So that definitely give us a clue that using both therapy would be beneficial for Mr. RT. Pharmacotherapy, no evidence so far that shown superiority of any of the antidepressants medication. So no antidepressant medication is superior than the other options. Patient is requested medication that does not cause any GI or sexual dysfunction symptoms. Bupropion is a good choice, as at least is it one of the least among the list of antidepressants that cause sexual dysfunction or GIC symptoms. It is also the first line of treatment in patients with major depressive disorder who are willing to quit smoking as well. So the recommendation length of treatment is from 6 to 12 weeks. Meta-analysis of patients data from 37 randomized controlled trial. Number of patients was 8,400 patients with major depressive disorder. Compared patient with MDD on venlafaxine and fluoxetine versus placebo. For 6 weeks, remission occurred who received the active medication than the placebo. So to monitor the symptoms, we need to see an improvement after 2 weeks. If no improvement after 4 weeks, consider treatment switch, or bupropion can be increased in that case too. So again, with bupropion can increase also the exposure of metoprolol, close observation for hypotension, bradycardia. If any of the symptoms occurred, we need to consider adjusting metoprolol dose or switch to bisoprolol after consulting the patient cardiologist. Now we're going to talk about his COPD problem assessment. Last exacerbation was last March 2019. No hospitalization, frequent symptoms, but still there's a frequent symptoms such as shortness of breath while walking or exercising. Patient is still active smoker, 1 pack per day. His FEV1 is reduced to 60%. The normal measurement is always above 90%. His FEV1 compared to FVC ratio is 0.63, which was reduced. The CAT score was 23, and that's above 10. According to the GOLD guidelines 2020, patients lies under GOLD 2 group B. Assessment of treatment plan. Patient is currently in short-acting beta agonist, inhaler albuterol, and an inhaled corticosteroids. According to GOLD, this is not the perfect therapy and it's an inappropriate treatment for group B according to GOLD standards. Treatment plan should be changed accordingly. So the goal of treatment: decrease or eliminate breathlessness and improve exercise tolerance, prevent COPD exacerbation or hospitalization, and improve quality of life. Recommendation: discontinue albuterol and fluticasone. Start long-acting beta blocker as formoterol fumarate, 12 microgram per capsule, 1 capsule inhaled BID a maximum of 48 microgram per capsule, as 2 capsules inhaled BID per day. Rationale: according to the GOLD guidelines for Group B, monotherapy of long-acting bronchodilator is recommended with escalation of dual therapy if symptoms persist. Consider, of course, we need to consider smoking cessation. That's for better improvement of the patient status. Also, encourage the physical activity to reduce the risk of immobility. No vaccination is required at this stage for the patient, as he has vaccines for pneumonia and flu vaccine. And also, he should really manage his weight and follow a diet accordingly. Monitor symptoms should be improved. Shortness of breath should be less. Medication side effects such as tremor, nervousness, hyperkalemia. So we need to check serum for potassium, tachycardia, and palpitation. So that is actually my presentation, and that's my recommendation for Mr. RT. He should be back within 4 weeks for another follow-up with the clinic to see if there's any improvement has happened to these symptoms. Thank you. Have a great day.